And then they follow that up with a PHQ-9 if the patient screens positive on the PHQ-2. In a couple of instances, we do have some practices that use the PHQ-9 for the initial screening, but that seems to be much less common. So this screen shows you what the PHQ-9 looks like. It's 9 basic questions. There's a pretty basic scoring algorithm, and then there's another question at the end that asks about how the problems in questions 1 through 9 are impacting the patient's life, how difficult they're making the patient's life. The PHQ-2 is actually just a shorter version of the PHQ-9. It's composed of the first 2 questions, and then a score of more than 3 indicates a positive screen for depression. And you can actually find there's much more detail available online. I've provided a link to the PHQ-9 tool as well as some scoring information. There's a website that has a pretty extensive list, not just on the PHQ-9, but some of the related tools that are also available. And then they actually have the tool available in over 30 languages at this point. So for folks who are concerned about patients who have limited English proficiency who aren't able to read and write in English, there's a pretty good chance that you can use the PHQ-9 for other populations. What I should note, though, is that the PHQ-9 hasn't necessarily been validated in those other languages, and so, as with any tool that hasn't been validated in other languages, you should just, be a little bit cautious about the results. So the biggest challenge our practices face in screening patients for depression is really not doing the screening at all. It's really about what do they do when a patient screens positive for depression. And there are 4 basic problems that our practices seem to have when patients do screen positive for depression. So the first one is getting an appointment with a psychiatrist. We have a shortage of psychiatrists here in Rhode Island, and so it can be very difficult to get an appointment or to get an appointment quickly enough. Sites that have integrated or co-located behavioral health services seem to have fewer problems with that. And some of our practices have also attempted to establish what they're calling contacts with psychiatrists. These are essentially written agreements with a psychiatrist or any specialist that basically indicate what the roles and responsibilities are for jointly managing the patient population. And I provided a link to one example of a compact. There are a number of others out there, but there's one available on the CMS website if anyone is interested in taking a look at that. Appointments with therapists seems to be less problematic, although that can be difficult as well. Our providers also talk about a lack of communication from the behavioral health provider. I think there's a lot of concern over privacy around behavioral health issues, and that can be challenging. Where practices have integrated or co-located services or they have established contacts with providers, this issue around communication seems to be much less problematic. And in a lot of cases, it's simply relationship building with those behavioral health providers and establishing some clear guidelines around how they would like to communicate that really can make a big difference. Patient insurance and financial problems can certainly be an issue. Some of our sites, I think, attempt to manage depression within the practice using practice resources when insurance is a problem. But in many cases, our practices don't have behavioral health integrated within the practice, or they don't really feel equipped to manage a patient's depression, particularly for patients who have more severe depression. And so, it can be really difficult to overcome those insurance and financial issues. I guess one thing to note, though, here is that in some cases, practices are working with health plans, and some health plans seem open to modifying the copays and some of the insurance requirements around behavioral health for patients who are managed by medical homes. And so that's an option, is to try to negotiate that with the health plan if you have a good relationship with the health plan. And then lastly, our practices have indicated that patient follow-through on referral can be very difficult. There's still a lot of stigma around behavioral health problems. And in many cases, patients are just kind of stressed and have too much going on, and so even if they're not so concerned about the stigma, it just may be difficult to follow through on another appointment, particularly if there's they think it's going to require a number of appointments to get good care. Some of our practices have found that this issue of patient follow-through can be minimized through what's called a warm handoff, which is basically introducing the patient face-to-face with the behavioral health provider. Now, of course, you can't really do that if the behavioral health provider is off-site, but you could potentially do, say, a virtual warm handoff by introducing the patient by phone to the behavioral health provider. And in some cases, our practices have nurse care managers embedded within the practice in many instances, and so in some cases, they're just doing a little bit more diligent follow-up with those patients, particularly with the nurse care manager, who often has a relationship with the patient, to ensure that the patient is following through on the referral. Very occasionally, our practices will find that patients will question why they're being asked the screening questions. This seems to be more of a problem when a practice initially starts to do depression screening. Our patients, by and large, are pretty comfortable with answering these types of questions now, particularly patients who have been going to the practice for a number of years. And even the practices, when they first started this, it really wasn't a big problem. They just might have gotten a little bit of pushback from patients when they would start to ask the screening questions. So I'd like to tell you a little bit now about how we measure depression screening within the Beacon community. The Beacon community, we have a pretty strong belief in the idea that you can't improve what you don't measure, and we focus a lot on data-driven improvement within the Beacon community. And so we've spent a lot of time and energy developing a number of clinical quality measures, as well as a number of other metrics related to utilization and things. And we have a number of groups that actively work on making sure that all of our measures are updated regularly, and that they are consistent with national standards. So we have, for the Beacon community, we have a common definition of depression screening, and we have common reporting requirements for all of the practices. Our definitions for all of our clinical quality measures are based on national standards where there are national standards available. In most cases, we are utilizing meaningful use and the National Quality Forum measures to set our measures, although sometimes they require tweaks because we're reporting out of an EHR rather than, say, a health plan claims database. In the case of depression screening, when our depression screening measure was created, there really wasn't a national standard available. And so we utilized the Veterans Administration depression screening measure to create our own depression screening measure. All of our measures are developed by a committee of Beacon practices and stakeholders, and they're approved by a broader stakeholder group. And we review them at least annually, and then we update them as needed. And we work with other PCMH initiatives in the state to standardize measures across initiatives, so that, for instance, a practice that's part of Beacon as well as another PCMH initiative doesn't have to report on depression screening a little bit differently for each of those initiatives, that they can have one consistent measure that they can report to everybody. So I provided, just for informational purposes, I won't go through all of the details of it in the interest of time, but I provided our depression screening measure for anybody who's interested in seeing it. I'll just walk you through. This is a pretty consistent format that we have for all of our measures. So at the top, there's a basic description of the measure. We define it, what we consider an active patient, and where it's appropriate, we will exclude certain patients from that measure. It's typically, patients who have passed away or have left the practice, patients who have transferred to another practice. We define a measurement period. In this case, it's 24 months. We define a numerator. We define a denominator. We will list any exclusions, and those are typically patients who have a diagnosis or a condition that indicates that they should be excluded from that particular measure. We list our measure source, and then we list whether it's a process or an outcome measure. And in this case, depression screening is a process measure. And then we make all of those results, the data gets reported to us quarterly. We compile them. We make them available on a web-based reporting tool to the Beacon community. Within that tool, there's some security there, so only our practices and our stakeholders have access to it. But we also de-identify the data at a site and practice level. But we provide site keys so practices know, how each of their sites are doing relative to the Beacon community. We include some trend analyses as well as comparative analytics, and then we often offer group learning and best practice types of learning events so that our practices have a chance to talk to each other and learn from each other so that they can make improvements within the practices. So this is the latest results we have on the depression screening measure for the Beacon practices. It is aggregate level data, although we do have site and practice level data available as well for the Beacon community. This graph shows the results by quarter. The color coding indicates whether we have, for that quarter at an aggregate Beacon community level, whether we have attained our Beacon target. So at the start of the Beacon grant, for all of our clinical quality measures, we set a target. And in the case of depression screening, we set this at 60%. And I should note that we are striving to achieve it at both an aggregate and at a practice level. We want to achieve our target across the Beacon practices, but we want to also help to support each of the practices to achieve that target. So what you can see is we started out at about 50% across the Beacon practices, and we've made some pretty steady improvement from quarter to quarter, although there can be a couple of, it can fluctuate a little bit over time, too, in terms of the trend. And we're now up over 80% in terms of depression screening across the Beacon community at an aggregate level. I do want to highlight just a couple of or make a couple of comments about measuring depression screening. In some cases, our practices are achieving nearly 100%. We have a number of practices that have depression screening rates of over 95% at this point. I would just caution anybody to think that you're going to instantly be able to achieve 100%. It can take a lot of time. You're doing a look back over 1 to 2 years, depending upon how you define a depression screening measure. So it can take a while to start, to filter through all the patients that you've seen over the past couple of years and get to a point where your data is up to date and that, you've seen everybody recently. So it can take a substantial amount of time to make improvements on these types of measures where they look back over 12 to 24 months. The other thing is improving on clinical quality measures requires not just that you actually have done what your targeted outcome is, so in this case screening patients for depression, but it also requires that you document it in a reportable field within the electronic health record, and that you be able to report accurately out of the electronic health record, or if you don't have an electronic health record, that you have some other way of tracking it and reporting on it using paper or an Excel sheet or something like that. All of those types of steps are subject to some level of failure, and so in many cases, our practices actually probably have higher depression screening rates, but they may not be capturing it in a reportable field. Somebody forgets to capture it during an office visit. There can be a number of different things that can go wrong, and so actually achieving 100% or getting over 90% can be somewhat difficult. That you have to be really diligent at all of those steps, from the screening to the data collection to the actual reporting. And lastly, before I close, I just want to, for anybody who feels a little bit daunted about how to get started on depression screening or any other type of clinical quality measure, I would just recommend that folks start small. So rather than think, I have to screen every patient that I see from day one, if you want one approach so that you can start to feel comfortable with depression screening and feel like you're adequately equipped both to do the screening as well as to follow up on any positive screening results, is maybe just to start with a small subset of your patients initially. Maybe you start with doing it at the annual exam, or you start with one physician within the practice doing it, or you start by doing it one afternoon a week and start to feel comfortable with that process and work through the process initially on a small scale and then spread it more broadly within the practice. And this seems to work well at a number of our practices when they want to start doing something new. Rather than try to implement it whole scale, start small, start with one step, and then broaden it from there. You really don't need to feel like you have to do everything at once, that you can really build on just a small initial step over time. So I provided my contact information if anybody wants to contact me directly. Email is great, but my phone number's there, and so you're more than welcome to give me a call as well.
Excellent presentation, Jennifer. Thank you so much. And I think you're right on target what you said, too. Not only when you're looking to make improvements in the practice related to depression screening, but everything that you talked about relates to every aspect of quality improvement, to start small, pick a subset of your population, plan, do, study, act, figure out what works, what doesn't work. And it might take a while before you figure out a system that you really want to launch for the whole practice, and even starting with, one provider in the practice and then moving it to other ones. And certainly we encourage you to learn from all of these shared experiences that we have, what works, what doesn't work. Reach out to those people that you know in your community and around the country that have, gone down this journey, and learn from their pitfalls and their successes as well. So thank you, Jennifer. And again, we've got some great questions that are coming in. Continue to write your questions in the boxes, and we'll get those questions at the end of the presentation. We'll have plenty of time for the discussion and to get those answered for you. So let me see. Did we get Dr. Merkin back on the line with us?
I think so.
Oh, you are there. I can hear you great. Thanks so much. And, technology works great when it works.
Yeah, that's right.
So you should have control of the screen now. If you just want to click inside that screen and see if you can move those slides. There you go. The floor is all yours, Dr. Merkin.
Okay, great. Well, as I'm Dr. Merkin. I'm the now how do we go backwards? Here we go. Okay, I'm the CEO of Allied Pediatrics of New York, but I am primarily a primary care pediatrician. I just wanted to mention a little bit about Allied Pediatrics to put the rest of this in perspective. We are a large pediatric group now, approximately 96 pediatricians, and when you add in some of our NPs, we're about 120 altogether. Most of our offices are primary care pediatrics. We have one office that specializes in breastfeeding medicine, and we have a breastfeeding medicine division that provides services to all of our 24 offices, as well as one office that specializes in obesity and nutrition that also sends out practitioners to our other offices. We range in size from solo physician practices scattered mainly on Long Island, but this slide here shows you where our population is centered. The bright yellow is our densest population, and it spreads out from there. So we're primarily on Long Island, Westchester, and we have now a group in Rockland County. We have patients across the socioeconomic spectrum from low to high, and so we see the whole gamut. We're NCQA Level 2 certified medical homes. The practices now that are on EMR, approximately half of us have been certified as Level 3 medical homes. So that's where we're coming from. Now, we started screening for depression even before we were a medical home. I received a mailing from one of the insurance companies that I participate in, telling me about depression screening and the teen screen, and that's really what got me started. Anyway, it fit in nicely with the medical home concept, and suddenly we had our mental health component. And in pediatrics, I was sort of surprised to learn that it's such a big problem, because even the kids, we always asked about problems, always asked about stressors and home life, and most of the time, particularly in the teenage years, it's deny, 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 or everything's fine. When I started looking up the statistics regarding mental health problems, I found that reportedly 1 in 10 children and 1 in 10 adolescents seem to be emotionally impaired or suffer from a mental illness. Girls are actually affected twice as often as boys. And unfortunately, suicide is the third leading cause of death among 10 to 14-year-olds and 16 to 19-year-olds. Accidents and malignancies are 1 and 2 among the younger age group, and accidents and homicides are number 1 and 2 among the 15 to 19-year-olds. As I stated on the slide here, many of the adulthood mental health problems begin in adolescence, and hopefully we'll be taking some of the work off of Jennifer's end of the spectrum, but we can nip it in the bud on our end. So our target group is the 11 to 18-year-olds. We use the Pediatric Symptom Checklist, PSCY, or as I was introduced to it, also known as the teen screen. The PSCY has 35 questions that deal with depression, anxiety, conduct disorders, oppositional defiance, and they add 2 extra questions at the bottom relating to suicide. We found it to be very quick. That most of the teenagers can fill it out without a problem, although sometimes the 11, 12-year-olds need a little help with it. Unfortunately, they often grab the parent, but we try to block that and keep the parent away from it, and just tell the teenager to do the best they can. It takes approximately 5 minutes for most kids to fill it out. I usually do most of the scoring myself. It takes at most a minute, and I found it very quick and easy. The statistics that they have on the percent that are positive, 30 or more on the score, or yes on either of the suicide questions, approximately 14% scored positive in a school-based health center in a small city. In an inner-city public school, approximately 20% of 11 to 18-year-olds. And among the suicide questions, 3% responded yes to suicidal ideation in the primary care sample. 2% responded yes to the suicide attempt in the primary care sample. So this actually shows you what the teen screen looks like. There's a black and white version if you're scanning it. It makes it easier to scan it into the EMR. This is the version, otherwise it's identical, so black and white instead of colors, and it has, instead of the pink, anxiety, the blue for conduct disorder, oppositional defiant disorder, and the bottom two are the suicide questions. The thing that really seared this routine into my mind was when I first started to do this, I had an 11-year-old filling out the form, and he hands it back to me. Usually what I do is I flip it upside down and try not to look at it while the parent's in the room. And I go through the rest of my history and physical, and when I get down to the part where I ask the parent to leave the room, that's when I usually flip over the questionnaire. This 11-year-old had circled the question 36, during the past 3 months have you thought of killing yourself? And I looked at him, and I said, did you mean to circle yes? And he said yes. And I said, how long have you been thinking about this? And he said to me, since he was 7 years old. And I looked at him, and I said, well, but, how could this be? What's going on? He said, well, I hear voices. And I said to him, have you spoken with anybody about it? And he told me that he had tried to tell his parents about it, but his parents, just couldn't believe it. They thought he was making it up. They thought he was fooling around, and so he repressed it. And when he started telling me the story, he started crying. And I realized that this is one kid who I never would have guessed in a million years. And I was very, very happy to be able to at least recognize the problem and try to address it. The other thing I've found with this questionnaire is that, again, parents and the teen come in the room, I ask what's going on, and they say everything's fine, nothing new. And then I'll turn over the form, and of course they score positive on it. And I question the teenager, and they'll say, well, I'm going to a psychiatrist, or I've been seeing a social worker for 3 years, et cetera, et cetera. So there are problems that are already being addressed, and apparently they're comfortable with how they're being addressed, but it's totally not, I would never have known about it if it weren't for the teen screen. So I'm sure, as we all know, there's a lot of taboo regarding psychiatry and depression and everything else, and this just helps, I guess, get it out from under the table. As Jennifer said before, I think the biggest challenge for us has been what do you do when you get a positive. That certainly slows things down, and it has been a huge challenge to find psychiatrists and psychologists that are in network to address the problem. But we sooner or later we find someone to help us out with this and make sure that the kids get seen. The other question I had, that was brought to me by a lot of parents is, why are you asking my 11 and 12-year-old about suicide? What are you planting seeds in their head? And this actually was addressed by Madeline Gould at Columbia University, who published a very good study in JAMA in April of 2000. And she found that asking about suicidal ideation and behavior doesn't create stress, it doesn't create ideation, and even amongst high-risk students, they found that asking the question the attempters and the depressed students appeared less distressed and less suicidal than before. So just asking the question, I think it's similar to the experience I had with the 11-year-old, helps pop off the pressure valve. And the way they did this study was to essentially use a screen like the teen screen, but half the group had these suicide questions, half didn't, and then they compared the two going forward. So I've been very comfortable using this, and I try to reassure the parents that question my use of it that it's something that's valuable and worth doing. I have on this screen a couple resources. Actually, the most important one is at the bottom there. I created a shortcut to it. So we have one other thing we're working on now with the teen screen. We're trying to modify it a little bit, and we're adding a few questions that to attempt to pick up prodromal schizophrenia, bipolar disease in teenagers to see if we can grab these kids and alter the course before they become floridly schizophrenic. So we'll see how that goes in the next few years. And if you'd like to contact me, you can just Google Gary Merkin or go to alliedpeds.com, and be happy to get back to you. Thank you.
That's great, Dr. Merkin. Thank you so much for that presentation. I think you really brought everyone's attention who maybe hadn't thought so or put such a priority on depression screening, but how this can really impact the lives of the patients in your practice. And again, a lot of great questions that are coming in. But before we move over to the questions, I'm going to move the slides back down to our final presentation, and Foong Kwan's going to talk about some of the work of the special interest group that we have on behavioral health and some of the tools that they've developed and resources that are also available on the PCCC website. So Foong Kwan, I'm going to go ahead and turn control over to you.
Okay, great. I hope people can hear me. I'm afraid we're having our roof done, so if you hear some hammering, it's not me banging my head on the table. But welcome, everybody. Just very quickly, the first slide really is just to remind those of you who are not familiar with the PCPCC about the website, and also what their mission is to advance effective and efficient the health system, built on, as you just heard, the foundation of primary care and the patient-centered medical home. And the PCPCC itself currently has about 1,000 diverse stakeholders and growing, and hopefully hope to have more stakeholders as more and more people embrace the idea of patient-centered care. Let me tell you a little bit about the Special Interest Group for Behavioral Health, and it's wonderful to see so many names on the attendee list from what used to be the task force, and they have done so much to advance this, even the web pages and the resources on there, as well as a presentation. We are now the Special Interest Group. It's from the reorganization of the PCPCC, but so many, in fact, everyone from the task force has moved over, and we meet every 2 weeks, and it really is an informal group that sort of talks about what sort of topics they would like to discuss, and they're also very, very active in some of the centers within the PCPCC. And for those of you who are interested, this is actually a day when the group would normally meet, so in 2 weeks' time we would have another call, and I provided the passcode and number. Okay. It was working before, and now I cannot. Oh, here we go. Okay, so let me tell you a little bit about the background of the resource while I try to get us onto the PCPCC website to actually show you the resource. There was a group of the special interest groups, we call ourselves the subgroup, to really work on what we call some quick implementation guides for anyone in primary care that was interested in taking the opportunity to screen for depression in adults for those who are Medicare eligible. And this was based on, in October 2011, the CMS decision to reimburse for screening, where the patient himself or herself would not be paying for co-insurance or a deductible. Amy, I need some help. It keeps jumping around on me. Here we go. And as you can see, this is actually a very, can be printed out off the website. There is a PDF, but essentially it describes the Medicare benefit, and it talks about the value to you and your patients and gives the procedure code for the screening. And as we go down, you can see also it talks about who's eligible to get the reimbursement, what the referral options are. We actually link to the PHQ-9, which I believe Jennifer spoke about, and this is available with no license fee, and it is available in other languages. Then the folks on the group also kind of provided a summary of what the different scores and proposed actions mean. And finally, on the bottom, we actually talk about what happens if a patient responds positively to question 9 of the PHQ-9 and what to do about that. And we also link to some additional resources. The ACP has an excellent depression guide, and also Health Teamworks out in Colorado has some wonderful resources. And actually on the, I don't need to scroll down to the bottom of this because the second page is really the PHQ-9, which Jennifer already showed. I'm waiting for, I think Amy's going to go back to the presentation for me. So again, this was just a summary of some of the things that we cover on the resource. And I wanted to acknowledge everyone on the special interest groups, because once we actually had the resource, we did go back to the larger group, and everybody provided some really helpful feedback. But I did want to acknowledge the folks on the subgroup that did the heavy lifting. Thank you, Amy.
Excellent, Foong Quan. Yeah, and for all of those of you who joined the webinar today, if you're not already signed up for the special interest group on behavioral health, we do welcome you to participate on that. You don't have to be a dues-paying member within the PCPCC to participate. So you can get linked up through our website. If you click on behavioral health, you get linked to the special interest group. Or if you just want to send me an email, we can get you added to that list as well. And again, you know, they meet about twice a month and have some incredible dialogues and have put together some great resources that we hook up on our website and get you access to as well. So I think we're going to go ahead and start rolling out some of these questions. Again, thanks to all of you who've been participating and been so patient in getting your questions answered. One of the things, I saw a lot of questions that were making reference to electronic medical records. So Jennifer, maybe you can start and kind of talk about, especially through the Beacon program, how depression screening is being linked into the electronic medical record, how that's a tool that's been useful in terms of overall population management and looking at screening overall, and then how follow-up is happening. And I don't know if you want to talk more specifically. There are some questions about specific tools, EMRs, that are being used in the Beacon practices that you're working with. So if you'd like to take a first stab at that, that'd be great. Oh,
Sure. So,
Jennifer, you might, go ahead. We can hear you now.
Good. So the practices within the Beacon community use a number of different electronic health records. I forget what the latest count was because it kind of changes over time as practices upgrade or switch EHRs. But, you know, we have GE Centricity, Allscripts, Greenway, EpiChart, which is seems to be more of a Rhode Island-based product, NextGen, eClinicalWorks. So there are a variety of different electronic health records. And then in most cases, practices are using patient registries, either I think in most cases they're integrating EHR, and then they also have patient portals and other things that allow them to connect electronically with their patient populations. Some some of the electronic health records, I don't believe it's all of them, have the PHQ 2 or 9 embedded, integrated within it. Or where it's not already integrated into it, the practices in some cases have customized fields so that they can capture the screening questions within the EHR. Regardless of whether it's integrated in order to do depression screening out of the EHR, the practices have to be able to capture the screening results in reportable fields within the EHR. And in some cases, honestly, our practices have struggled in terms of figuring out what's a reportable field and what's not. Kind of a dirty little secret of some of the EHRs is that some fields that look like they would be reportable, actually when you dig into the EHR, they're actually not a reportable field. They're not something that you can easily pull from or that you can pull from at all in some type of report. So you know, we've worked to support our practices to make sure that they are able to capture the screening results within the EHR and accurately report out of it. But, you know, this is all kind of subject to a little bit of, you know, there are always problems with it. You know, there's always human error involved, and electronic health records are by no means perfect either. I think there were, Amy, you said there were some questions about follow-up. Were those related to technology, or were those just kind of general questions about follow-up with patients who screen positive?
You want to talk a little bit about maybe how EMR is being used to help facilitate any follow-up or communication back and forth with the mental health providers?
Sure. So, you know, this is an area that's really going to vary by practice. And in some cases, it varies because, you know, the practices to some extent have to kind of pick and choose which conditions they're going to be most concerned about. So practices that are particularly concerned about behavioral health issues are probably going to be better about the follow-up and the tracking of positive screening results than, say, a practice that, say, is most concerned about its HIV positive population or its population with diabetes. And of course, it's going to vary across practices just in terms of what how they're organized and structured and what type of resources they have within the practice. So, for instance, a community health center that has a lot of centralized administrative function it is often better equipped to be able to systemize some of the follow-up and the tracking versus, say, a solo practitioner who, you know, has a very small staff within the practice. We work with a couple of Frankel practices as well, and so the resources can be very different within those practices. You know, the trick to this is having some type of effective tracking tool, and it can definitely be a tool that is based out of the electronic health record, although some electronic health records are not, that may not be their strong suit. And so in some cases our practices are actually utilizing Excel spreadsheets and other things to track patients who have some type of follow-up that they wanted to be able to monitor and to kind of stay on top of. So the short answer, I realize that was kind of a long-winded answer and probably may not be that helpful just in terms of concrete things. It really varies from practice to practice, and it really varies based upon what type of resources the practice has, how good their electronic health record is and what tools it has available, how well they're able to utilize all those tools, and what other types of systems they have in place within the practice.
Great. Thanks, Jennifer. Dr. Merkin, do you want to address that question? Maybe talk a little bit specifically about how the EMR you're using is helping to facilitate depression screening, if it is, and if not, what are some of the barriers that you're still facing with the EMR as it relates to this?
We're at the stage where right now it's not facilitating. We can track whether it was pass, fail, refer, refuse, things like that. We're
great. Yeah. So there have been several questions that have come up around how the staff, the clinical staff in the practice, is trained as it relates to depression screening or maybe even mental health more broadly. Everywhere from the medical assistants who are involved possibly in the screening, how much training, if any, do they know, all the way up to the physicians or nurse practitioners in the practice. What level of training do they need, and maybe how much of the clinical care related to depression is being done in the practice, and then at what point is the patient referred out to more specialized care? Dr. Merkin, you want to address that first?
Sure. Well, as far as attention problems, I think for a lot of pediatricians, we've been dealing with that for years. So, those of us who feel comfortable, diagnosing, we don't use the teen screen to necessarily diagnose ADD, but we use it as a flag that we have to do further screening. So we'll follow up from there, and then if we decide that the child needs medication, most of us feel comfortable prescribing some medications, not the whole broad spectrum of ADD medicine, with psychological counseling or therapy. For attention problems, most of us have a network we can rely on. We hit a roadblock with all the other problems that we're screening for. So that's really where we're at right now. We tried to, we're still attempting to establish a mental health division for allied pediatrics, so we would have our own stable of people in network that we could rely on to take care of the patients. But that's been a huge challenge as well.
Right. Yeah, I know a lot of people all around the country are facing those challenges in finding the right people to make those referrals to that have the right skills to address the particular population. Right. Jennifer, what about in your state, in Rhode Island? What kind of training and what kind of services are being provided within the primary care setting specific to depression?
So, I think this is, again, is going to vary a lot within the practice. Practices that have integrated or co-located services are obviously going to be much better equipped to handle things within the practice. And in those cases, I think they're probably more likely to refer the patient to a behavioral health provider versus try to manage the depression internally within the practice. Some of our practices have fairly large uninsured populations and a lot of patients on Medicaid who they may be particularly challenged to provide referrals to psychiatrists and others. And I think in those instances, our providers have, actively sought more training to be able to manage depression within their practice, so they're not having to refer quite so many patients out. And that, of course, is in some cases their own defense mechanism, because all of those referrals and tracking those referrals and making sure that patients get appropriate care, all of that can require a substantial amount of time within the practice. As far as the formal training around depression, we've done a little bit around within the Beacon community as a whole. I would say it's probably, I think we haven't done nearly enough to support our practices. And so we have a lot of variability just in terms of how well trained our providers are in terms of managing depression and how comfortable they are. I think a lot of our practices rely on their nurse care managers, many of whom have behavioral health and home care backgrounds, have some experience in dealing with people with mental health issues, and in some cases are supporting those nurse care managers with some additional training to help patients, particularly patients who maybe have comorbid diabetes and depression, or some other type of physical health comorbidity in addition to depression. But I mean, that again, it's going to vary a lot from practice to practice. I think we definitely have some providers who feel very comfortable and very well trained to manage depression within the practice, and some who still struggle quite a bit with how to provide good care for their patients in this area.
Great. So Jennifer, can you tell us what the success of the practices you've been working with have been in terms of getting reimbursement? We know from what Quan showed us, there's reimbursement through Medicare now. What about the private health plans? How successful have they been in getting reimbursed for the screening?
To be honest, I don't know the answer to that question. Honestly, it hasn't come up a lot, and it's not something. I haven't heard a lot of complaints from our practices about not being able to get reimbursed for this, but that doesn't mean that it's still not an issue. A lot of our practices are a little bit unique. They rely a lot on fee-for-service payments for the care they provide, just like a lot of other providers do, but they, by nature of their PCMH contracts with health plans, they get some additional resources to manage their patients. And depression screening is an expectation of receiving that reimbursement. So, for instance, the practices within the state's multi-payer demonstration of the patient-centered medical home receive between $5 and $6 per member per month for all of their insured patients within the practice, and that's to provide a medical home level of care for those patients. And that's in addition to fee-for-service payments, as well as any other special incentives the practice has negotiated. So I think in some cases, I'm guessing, but I would guess that in some cases our practices are they look at depression screening as a requirement of their PCMH contract, and may not be actively pursuing depression screening reimbursement in the same way that a practice that doesn't get that type of reimbursement would.
So possibly they're putting it under their umbrella, the capitated fee or per member per month fee that they're getting to provide those more enhanced services in patient-centered medical home.
Yeah, and it's going to be, I think just like any other primary care practice, some of our practices are a bit more savvy at maximizing reimbursement for, making sure they get all the possible codes in there that they can. And in other practices, it's less of a concern, and maybe they're not pursuing all possible reimbursement that they can related to things, to depression screening and other things. But they have a little bit of they have some additional security, at least financially, because of their PCMH contracts.
Right, right. How about, Dr. Merkin, what's the environment like in pediatrics, either from your own personal experience in your practice, getting payment for depression screening, or even what you're hearing from your colleagues nationally?
Once we got the mechanics of what modifier to put on what code for which companies, most of them pay for it. I'm surprised what they do, and they're very happy.
That's fantastic news to hear.
Yeah.
I mean, certainly we hear a lot that, payment for different pieces and services that are provided, when there's not that payment, it really is a barrier to the practice, especially those that are still mostly operating in the fee-for-service environment. It can really be a challenge for the practice to implement those new pieces and bring that into their practice. So that's really good to hear.
Yeah.
Jennifer, can you talk a little bit more, and you may not have this information in terms of a formal survey or data collection, but maybe even anecdotally, what do you think is the environment like in those practices that have really integrated behavioral health services into the primary care setting? Do you find that the clinicians are reporting that this is something that's been very well received by their patients, or patients concerned about it? I mean, what's kind of been the feedback and viewpoint of the patients by having all that kind of in-house under one umbrella?
So most of our, I'll start off by saying that, I think in most cases we don't and this is true across Rhode Island, not just within the Beacon community, but in most cases we don't have truly integrated care here. It's much more around co-located care, although some practices are trying to more actively integrate behavioral health, sort of truly integrate behavioral health within the practice. Most of the, I'm a little bit removed from patients, but we have done some patient experience surveys and some other things across the Beacon practices to get feedback, not just on behavioral health, but sort of other issues or other areas of the medical home. And you know, where services, not just behavioral health, but other services are integrated within the practice, both in terms of feedback from patients as well as what we hear from the practices, is that it tends to be much more successful and much better received, both in terms of patients' access to the services, their follow-through on it, their satisfaction with the services, and then the provider's ability to provide, to communicate and coordinate with those other providers. Where services aren't integrated, there are a lot of challenges around coordination and communication. So overall, I would say it tends to be much better. That we tend to hear very few complaints about sites that do have services integrated or co-located.
Great. Thanks, Jennifer. Jennifer, there was a question specific to how your organization has decided which ICD-10 diagnosis codes cross over to the codes in your depression measure. Do you have any information regarding that?
I don't believe that work has been done yet. And in a lot of, we typically rely on national standards to get updated before we update our own measures, because we want to make sure that we're consistent with meaningful use in the National Quality Forum and others. And our process typically starts, we usually do a comprehensive review of all of our measures starting in the spring. And so we're kind of approaching that, we'll be approaching that new cycle of quality measure review. It actually probably starts kind of in late winter. And so, you know, this is something that our committee will need to do. As far as I know, it's not something that's been addressed yet.
Okay. So, Jennifer, this is again to you. Since you've been working with a lot of practices, and you were talking specifically about a lot of the comorbidities, has there been any data collection or anything that you can report that's demonstrated that once the issue of depression has been addressed, then they're actually seeing improvements in their other chronic condition management? So, you know, we hear a lot about how depression can be the barrier to a lot of those behavior changes that we seek in patients with hypertension and diabetes. Do you have any information to share regarding that?
No, you know, we've certainly heard that anecdotally from some providers. You know, often we hear things about, oh, you know, I was screening this person for depression. I've known him for 15 years, and I just found, because I screened him, I just found out that he has depression and has had it for a number of years, and he never told me. And, you know, there are stories like that, but we don't have data at this point that allows us to make those types of connections between depression screening and identification of a patient with depression and other health outcomes. A lot of we do have data on things like blood sugar control for patients with diabetes, blood pressure control, LDL control, those types of things. But there are so many other factors that could come into play in terms of a practice's ability to manage their patients and achieve good outcomes for their patients with chronic disease, that I don't think we would feel comfortable making that link between depression screening and chronic disease outcomes.
Okay, yeah. Like you said, it certainly does make sense that would be an improvement, but certainly an area that maybe we can seek some additional data collection around, because I think that would be a significant way to promote the importance of depression screening, certainly amongst clinicians, but also for the patients to be more receptive and thinking about it in those terms as well. Dr. Merkin, there's been some questions around how do you deal as a practice with some of the challenges that you might face if you identify an adolescent who has some issues that you feel needs to have a referral made, and you made that referral, but you find out later that they didn't follow up. What's the process that you have in your practice for addressing that? And then also the question around what if you have a patient who says, you know, I don't want you to tell my mom or dad. I'm concerned. I don't want them to know about this. I mean, do you address that prior to the screening to let them know that this is going to be disclosed, or how do you deal with some of those issues?
Well, I'll deal with the second question first. I tell the team right off the bat that they do have confidentiality with me, but I do let them know that if I feel that their life is in danger or someone else's life is in danger, that I need to share that and I need to do what's best for them. I don't think most of the teenagers, almost all the teenagers I deal with, they're okay. You can talk to them when you talk to them before giving them the questionnaire to get a preview of any issues. It's usually a quick no, yes, and everything's fine. But once they answer the questionnaire and you start talking to them directly about some of their answers, they're pretty open with things, and most of them are very, very happy to let me speak with the parents about it. The questionnaire that we're piloting now to pick up the prodromal schizophrenia, we've also included some drug screening. Do you use drugs? Have you used drugs? Alcohol, cigarettes, things like that. And even that, the teenagers don't. I usually don't bring it. I tell them things like that. Unless I think they're in bodily harm risk, I tell them that I'm not going to share that with the parents. But most of them don't. They're happy to get it out, I think. So it hasn't been a big issue. With making sure the patients get follow-up, sometimes I put a flag down and I have an EMR. I put a flag on my desktop and to remind myself to call them in a couple weeks to make sure that something's been arranged or that they've gone to see the psychiatrist. Sometimes I just have to keep dogging them to get them to go.
Right. Jennifer, maybe the same question to you, but even elaborated. There was a question that came up about how do you deal with making referrals to mental behavioral health services for populations of diverse cultures and backgrounds. In some cultures, we know there's a lot of stigma attached with going to see mental health providers and sometimes a higher dropout rate. Have the practices you've been working with in Rhode Island addressed that specifically with certain populations?
Most of so the practices that's primarily going to affect are our community health centers, and we have a couple of private practices that have fairly diverse patient populations, but it's mostly the community health centers. Our community health centers tend to have more integrated and co-located services within their buildings, and so I think in a lot of cases they're managing it with internal staff, and they're able to provide care through the other services they offer within the practice. And so to some extent, because they already have that relationship with the practice, with the patient, they're able they have that trust with the patient, and they're able to provide care that the patient might be a bit more responsive to than, if the patient has to leave the practice and follow through on a referral with a behavioral health provider who's not affiliated with the practice. So I think it's still an issue. I think it's a big problem. I don't think we have I don't think we certainly have solved it, although I think the practices they do the best they can knowing their patient population to design the services and offer the services that are going to be, culturally responsive and meet the specific needs of their patient population.
Great. Jennifer, I want to go back to that issue of integrating behavioral health into primary care. There are some kind of specific questions around if you're a practice and you're thinking about inviting a behavioral health, mental health specialist or psychologist into your practice, do you have any kind of tips that you could give the practice in terms of thinking about what size population they would need to support a full-time or a part-time practitioner, kind of what's the staffing ratio that's needed to support the addition of that type of clinician and space, and what types of, how many contacts do they need? So kind of thinking through that, what are some of your suggestions?
So I think there are a couple of things that the practice needs to decide. I think they need to decide what's going to be the role of that behavioral health provider. So practices can co-locate or integrate behavioral health, and that behavioral health provider is there specifically to address the mental health needs of the patient population within that practice. We do have some practices that have or are attempting to integrate behavioral health services to focus more on behavioral medicine. So they're not there so much to treat depression as they are to support patients who are trying to lose weight with some behavioral modifications and behavioral medicine types of approaches. So I think deciding on what the role is of that person, of the behavioral health provider within the practice is important. I think in talking to some of the behavioral health providers that I know who are in co-located sites, I think it's about a one provider to, or one behavioral health provider per 3 physicians. I actually think that ratio is a bit off. I think, and of course it's going to vary depending upon the patient population. If you have, a patient population with a lot more of severe types of depression, a lot more behavioral health needs, you're going to need probably a much lower ratio of behavioral health providers per patient per panel size, or say per 1,000 patients within the practice. But I also think there are a lot of behavioral health needs within practices that don't get addressed. It's really easy to co-locate a behavioral health provider and very quickly fill up a behavioral health provider schedule. Part of the issue, and I think this is something that sites can really struggle with, particularly if they don't have a really strong working relationship with the behavioral health provider, is that primary care and behavioral health have very different cultures in terms of how they view patients, what a typical visit would look like, what's the duration of care. There's a site that's actually not within Beacon, but that I've done some work with here in Rhode Island, where they have redesigned the behavioral health care that's provided within that practice to be much more consistent with how primary care is delivered. So rather than an hour initial appointment, they do a 30-minute initial appointment. Rather than, an hour follow-up appointment, they do a 15-minute follow-up appointment. And they've focused a lot on making sure that that behavioral health provider is available to meet with the patient, to do that kind of warm handoff, to do that face-to-face introduction, and also to make sure that the patients can very quickly see the behavioral health provider. One of the things that can happen is once you start screening patients for depression, you can identify a lot of patients who have behavioral health needs that you never knew about, and in doing so, you can very quickly fill up the behavioral health provider's panel and create wait lists. And when you create wait lists, you get a lot of no-shows, a lot of patients who don't follow through. And so by making sure that you can, shorten patient appointment times, do some very quick, you can do kind of short, short treatment plans around behavioral health within the practice, and then for so that you can cycle through patients fairly quickly, and then refer out for longer-term treatment for patients who maybe have more intensive needs that you can't address through those very brief appointments and through, say, a 1 to 2 month plan of care around behavioral health.
Excellent. Well, we have reached the end of our time allotment. I want to thank both of you, all of you, so much, Foong Kwan, Dr. Mirkin, and Jennifer, for your excellent presentations and information that you shared today. I think so much of what we talked about, again, and certainly what Jennifer was just referencing, is when we're really looking at building medical homes, it's really important to look at what skill set you currently do have in the practice, and how you can build on that to address the needs of the patients that you're serving, but then to also think about the technology and resources that you might need to employ to really get that grasp of what your population looks like overall and what those needs are, and how you can either connect to those that are available in the community or when it makes more sense to bring those into the practice and building out your overall care team, and then really delineating who is responsible for what aspect of care on the team, and that is communicated very well and in a way that's easily understood by everyone in the practice, specifically that the patients know who they can reach out to at what time when they have any particular issues. And again, a lot of this comes back to just really having that trusted relationship with the patients in the practice and helping them understand that whether it's a mental health issue, whether it's an issue that someone else in their family is facing that's impacting their health related to increased stress. I mean, there's so many things that we know impact the overall health of our patients. I think if patients understand that the primary care setting is the place where they can get information and resources to help them address those and live those healthy lives in their community, that's the ultimate goal. So again, thanks to everyone. We will have this this presentation available up on our website early next week, if not by tomorrow. So we'll also include that in our newsletters and communications moving forward. You'll have that direct link to the archived webinar as well. So again, thanks to all of you, and if we don't talk to you next week, then have a great Thanksgiving holiday, and we'll talk to you soon. Bye-bye, everybody.
Bye-bye. Thank you.